Good afternoon, all. Good afternoon, Dr. Chitra. So, welcome to our 14th session. Today, we are having our second class on mental health issues. We have Dr. Chitra to take session for us. So, we can start with ma'am's presentation. We can have it till 3:40, followed by 20 minutes of discussion. By 4 o'clock, we can start our case presentation, followed by its discussion. We can wind up our session by 4:30. Thank you all for joining in. Over to Shreya.
Hello everyone, I'm Shriya. I work as a resource mobilization manager at Pallium. Dr. Chitra is a very familiar face now. This is the second session that we are having with her. It gives me immense pleasure to introduce her again, and she has tons of experience in the field of palliative care. And just a little brief, she's also a professor in psychiatry and palliative medicine. She's a consultant in psycho-oncology in BCMCH Tiruvalla, and she's also the director of Mehek Foundation in Kochi. Over to you, Chitra ma'am, and we're looking forward to this great session. Thank you.
Can you hear me? I think you should.
Yes, ma'am, we can hear you.
Can you? I'm just going to do a continuation of the sessions I did a week back. So the slides will be in continuation. So you remember we were discussing about a person, a 68-year-old man with lung cancer who had poor response to treatment and had bone secondaries. And the history was that he had recently lost his son. He's supported by his wife, and he came with the complaints of not sleeping, being very edgy and getting irritable. With this case scenario, we had discussed about how we can look into the psychological issues in terms of concepts. So we had talked about quality of life, we had talked about distress, we had talked about suffering. So today we are going to do further from that to look into how practically we can look into how to help him. Is that okay? I'm going ahead. Next slide, please. So the questions that we asked is, so I'm going to catch on anxiety. So you can, depression will come along with that. So today, basically, I'm going to look into anxiety, depression, and adjustment disorder, so that these are the commonest psychiatric categories that we see in a person in palliative care. And if you need to look into any other categories, we should have another session, I suppose, because we wouldn't have time. So the question is that, is it normal for a person to worry after being diagnosed with cancer? And we know that it's absolutely normal for a person to worry after being diagnosed with cancer. All of us would worry. But then the question is that how do we differentiate between normal worry and anxiety disorder? Okay. So next slide, please. So when do we actually look into, because it's very easy for us when people discuss patient experiences, like teen comes from home visit or any other place, they would say that a person is very angry or worrying or crying. So emotional reactions are easily picked up by people. But then how do you actually identify as emotional reaction being pathological? That is, when is it not normal? Okay. So there are I'm just giving you 3 tips where you can think that, okay, this is not normal, this is beyond coping for the person. So we should look into ways of helping him. So suppose the emotional reaction is out of proportion to the level of threat. That means, for example, if a person has severe panic attacks while even thinking of chemotherapy, if the person has been kind of included, or there's a prescription for chemotherapy of 30 sittings or something like that, and the person after the first one or even before that, even the thought of it or even anticipating it, or during chemotherapy, has severe anxiety leading to panic attacks. If there is persistence of the symptoms or deterioration of the function of the person without intervention, that means if there is the symptoms of anxiety or worry which is persisting for weeks or months and there is a deterioration of the person's functioning, that is, this persistence of the symptoms actually affects the domains of functioning of the person. So the duration lasting for weeks or months. And third is the intensity of the symptoms which are unacceptable regardless of the level of threat. That means if there is continuous anxiety symptoms like palpitations, or the person has completely lack of sleep, or the person is not able to cope at all. So these are the situations where you think that, okay, if the person even has worry, this is pathological. We need to give the person an extra help. Next slide, please. So when we go back to cancer, so suppose this person, we have to look into what are the stage specific challenges. Like in the initial stage of cancer, usually a person has reactions to the diagnosis. Somebody, because he comes to the hospital with complaints, is diagnosed to have cancer, then he's left with coping with symptoms and treatment. And also there is a sense of loss of control from his life. The second stage is remission, where there is remission from after treatment, but still the person is left with uncertainty regarding, oh, whether will I get the cancer again, or whether I'll have further issues from this disease. And there is always usually sometimes a physical damage which is a painful reminder to him of the illness. Like suppose there is a stoma, or there is loss of hair, whatever it is, or a surgical thing. Like if you had a head and neck cancer and you had to undergo a major surgery, then whenever you look into the mirror, then you are reminded, it's a painful reminder of the illness that you have. The third is after the remission, then you have a relapse, usually, commonly. Then there is a sense of disappointment. Though there is a certainty that, okay, I've got the disease back again, or I've got a metastasis again, the disease is spread to another part of the body. So there is severe disappointment that, okay, the disease has progressed. And there is also fear of painful death. Along with all this, in our society, in a country like ours, our people also have problems interacting with the system, that is the health system, like the hospitals, the teams, the family, the society. There are so many hurdles that a common man has to cross to get a good treatment and also overcome the challenges. Next slide, please. Also, when we look into, I'm just going a bit to the other side and telling you what is the global burden of mental ill health. When you look into WHO, the World Health Organization statistics, depression is the fourth leading cause of chronic disease burden. So chronic disease burden is the burden which is measured by WHO, statistical measure, which measures the impact of a disease in the globally in terms of, and it is measured by called DALYs. DALYs means disability adjustmented life years. So that's something for you. If you want, you can go and read. So the chronic disease burden is something which we have to keep in mind, because palliative care deals essentially with chronic diseases. So depression is the fourth leading cause of chronic disease, and it is said that depression will soon become the second leading cause of chronic disease burden. That means that you would soon see depression as a comorbidity with any disease that is along, like a diabetic person will have, a cardiac ill person will have depression. So this is going to be seen in many people more with other chronic diseases also. And annually, nearly 1 million people die of suicide. And to remind you, yesterday was the World Mental Health Day, and the theme was that mental health promotion and suicide prevention. So suicide is becoming very common. And as you know, especially in India and in a state like Kerala, where we belong to, I know there are people from other states, suicide is becoming very common. And much of it is related to the mental health. Next slide, please. When you look into the spectrum of disorders in a palliative care population, so this is about cancer patients, the study. When you look into, when you study the prevalence of psychiatric disorders among cancer patients, this is the cross-section. This is one of the earliest studies done by Derogatis, which is very significant. And it shows that around 30% of people have something called adjustment disorders. 6 to 7% have depression. Anxiety disorders come to around 2 to 3%. You have organic mental disorders, which is delirium, and alcohol and other disorders around 1%. So if you look into it, at least half of the people referred have some issues, some psychological issues. But most of the reference to a mental health facility is usually for depression or for delirium from an oncology unit or a palliative care unit. Next slide, please. So I'm just going into the evidence. There's so much of evidence regarding. You can read a lot of evidence which is available now in journals into what is the prevalence of either anxiety, depression, and adjustment disorders. in oncology, hematological, and palliative care settings. So this is a meta-analysis looking into the prevalence. And again, if you look into it, anxiety disorder is around 10%, major depression is around 15%. There's something called dysthymia, which is 3%, and dysthymia is actually chronic depression. That is, you have depression for more than 2 years without respite. The depression is continuing. You call it dysthymia. Next slide, please. So let us get back to anxiety. So when you're looking into anxiety, especially in a palliative care setting, being a mental health professional, we diagnose anxiety disorders according to either DSM-5 or ICD-10. There are specific criteria. So each disorder has specific criteria which will define the disorder. Okay. So in psychiatry, the diagnosis is usually we have every disorder which is defined in ICD-10 with specific criteria, and we look into that because as you know, mental illness doesn't have any objective measurement. Like you cannot do an MRI and diagnose it as depression or anxiety, or you cannot do a blood investigation, or you cannot have any objective measurement. So we rely a lot on the specific criteria that universally has been agreed upon by organizations like WHO. So ICD-10 is one main system that we follow. But it is very difficult to apply the strict criteria of specific anxiety disorders to patients with advanced life-limiting disease. That means when you have in an oncology or a palliative care setting, it is very difficult to look into all that criteria and diagnose anxiety disorders. But we should understand that these people experience symptoms of the anxiety that cause significant distress or functional impairment. So we should always be aware that people with chronic diseases or advanced cancer will have significant psychological distress. Often when we do assessments, we forget about this. We actually look into the physical symptoms so much. The pain which we measure is always confined to the physical pain and treatment of pain with morphine. But when you look into total pain, the psychological aspect has to be really taken seriously. So when I am talking about anxiety, we can say that anxiety could be part of, remember I said that there are three main, it can be either part of adjustment disorder, it can be part of depression, or it can be part of specific anxiety disorders like generalized anxiety disorder, panic disorder, or obsessive compulsive disorder. I'll talk about it briefly, don't worry, because you're not expected to know very much in detail about the classification, just to be aware. Next slide, please. So we are going back to Mr. A again. Remember, we talked about him again and again when we were trying to explain the concepts. So some points about so what I'm going to focus here is about how do we assess him. So that as a primary care team in palliative care, we should assess them very well so that we are able to identify the distress. So these are some pointers which I'm going to give you so that when you have a person in front of you, you go about in a systematic manner to assess. So when you take his history, then you ask questions like, does he know about his illness? So does he worry about his losses? Remember, I told you in the history he has lost his son. So how does he worry about his losses, the loss of son? How is his relationship with his wife? Is his wife very supportive? We know that his wife is there, but is she really very supportive? Looking back into his behavior, ask questions like, how did he actually cope in the initial stages of cancer? Remember, we talked about coping last time, different methods of coping and what is mature coping and immature coping. I'm not going back to that, but remember that coping is very important to understand how a person copes. Is there any reports of his nature being always a worrying type? So there are many people who are known to be a worrying type, an anxious type. So was he a person like that? So if in your personality, if you have traits of anxiety, if your family has other members have traits of anxiety, that means that you are at a risk of having a reaction of anxiety to a stress much more than another person. So who is supporting this person? Are there any resources for emotional and other support available? I mean, either in the family, friends, or from the community. Is there neglect? Remember that he's a 68-year-old man. We should know whether as an elderly, he's close to being 70. For a person who's aging, is he being neglected by the family or by the community that he lives in? So these are very important questions. Next slide, please. So what are the risk factors? What should alert us to identify anxiety disorders? So one is trauma, history of traumatic events in childhood. Chronic illness itself is a risk factor. And of course, we know that he has got cancer. Negative life events. How has his life been? Are there negative events in his life? So when you look into Mr. A, he had a history of, he has history of chronic illness. He has lost his son. How is his personality? Are there anxiety traits? Is he something called neuroticism? For people who are interested in psychological aspects, you can read about neuroticism or neurotic person. Does he have poor coping mechanisms? Does he avoid situations which cause him stress, which is not actually a good coping method? We actually have to help the person challenge or confront situations which threaten him and help him cope with the situation rather than always avoiding it. And also gender. Females are at more risk to develop depression or anxiety in a ratio of 2:1, like from a female to male, 2:1. Next slide, please. Past history of mental health disorders of treatment. So you should look into whether there is a history of person having any consultation with a psychiatrist or a mental health professional. Has he taken help for coping or, even taken any medication for depression or anxiety? Is there a family history of mental health disorders of treatment, which also includes substance use, especially alcohol? Presence of other mental health disorders in the same person, like even if the person has anxiety, does he also have depression or is he also taking alcohol a lot? Substance use is very important. Does he have chronic pain? With an advanced disease like cancer, there is every chance that he could have pain which is unmanaged or recurrent or even chronic. Is there recurrence of the disease? There is recurrence of the disease in Mr. A. You remember that he has come back to you with poor response to treatment and with bone secondaries. Are there disfigurement? Is there disfigurement or any other embarrassing issues like colostomy, visible scars, body image disturbances, which all, destroy or demoralize the person or reduce the self-esteem of the person or lead to poor coping? Next slide, please. I just want to stop a minute and ask you whether this is making sense. Hello?
Yes, ma'am. We are. Anybody wish to answer that?
Do you want to ask something or because I'm going, because we have only 30 minutes, I'm just going slide by slide. So is there anything or we can wait the last few minutes for questions?
I hope we can wait to the last, ma'am. You can continue now.
Okay, all right. So we are looking into, then assessment, we looked into the history, we looked into how do we, find out from the history, what are the risk factors in the history that we look into. And then now we are looking to basic steps in assessment in your team. How do we do that? One is screening. Okay, for screening, remember, I don't know whether, next slide, just one more slide. Okay, go back, sorry. One more slide, yeah. So screening is looking into distress. So when that you look for pain, isn't it? You know the visual unlock scale where you score pain. Similarly, now settings, and if you look into guidelines from NICE or from NCCN in US and the Canada group, they say that routine screening for psychological distress should be incorporated in your clinical practice. So the team, when they score for pain or any other thing, distress or psychological distress should be one of the other signs. And in Canada, this has been included as a vital sign, just like pain. So other than the regular vital signs, pain has been included, and also distress, psychological distress has been included, so that in a routine clinical setting, like either in the OP or the IP, a nurse would actually, just like you look for, pulse, BP, respiratory rate, and all this, daily, you would also look into pain and psychological distress. So routine screening, and if listening to the person, our communication skills, remember, always we should know how we should communicate with the person. So listening, active listening, asking the right questions, and interpretation of the mood and symptoms of anxiety. So how do we interpret the mood of the person and how do we understand the symptoms of anxiety? Another important step in assessment is linking with a person's functioning. This is very important. And when I mean functioning, it is not about only the physical activity. I'm going to talk to you about what I mean by functioning. One is the biological functioning, one is the social and occupational functioning, and interpersonal functioning. So biological is sleep, appetite, and sexual functioning. So a person, how is his sleep? What was his pattern of sleep before the illness? How is he sleeping now? What is the disturbance like? Appetite similarly, and also is there any issues in that the person has regarding to sexual functioning, the libido, which we never ask in our routine assessment, which is very important, especially for a young couple, or couple who has who have started a family, or or a child has cancer and the parents. So many, all these people, we have to look into these functions. Then you look into social and occupational function. That means how is a person performing his role in the society. So is he going to the church or temple, or is he going to a community program? How is he interacting with others? And then occupational, even if it's a housewife or any, even whatever functioning he does, how is the occupation that he's doing? Is he doing to his satisfaction? And then interpersonal function, that is, how is his relationship with his family, peer group, and the society in terms of communication and emotional transactions. Next slide, please. So again, the same thing, biological, which looks mainly into sleep, appetite, and libido, social and occupational functioning, and then interpersonal relationship. And then if there is any impairment in any of this consistently, that means that the person is not really coping well. So you have symptoms, the person saying the history, like, he's irritable, or he's constantly worrying, or he's panicky. And he's also saying that I'm not able to sleep at all. Or he's saying that I'm totally not able to eat because of the anxiety. Or I'm not able to really go for my job and perform. Or I'm not able to really interact with my family. I get irritable. I just withdraw from them. That means that he's not coping well. That means he needs help. Next slide. So then how do we screen? Because I said screening is very important. That is where we use questionnaires, especially when we want to we look at it in a, you have structured assessments available, use of questionnaires or tools. So a team can use that, so that you have every person assessed by the same tool. So you can use distress thermometer, you can use HADS, that is the Hospital Anxiety Depression Scale. You can use General Health Questionnaire or PHQ-9, but the most common or the easiest one which is suggested is, in a routine screening, is distress thermometer, which is again a visual analog scale. And how does distress screening help? It helps by enabling identification of people with distress, and it actually initiates a pathway for psychosocial care. That means that you not only identify it, so once you screen the person, it is actually a tool not only to identify distress, but it also is a tool which helps open up conversations about distress. That is, when you actually screening the person, you're asking about the psychological distress, asking to rate. So naturally, it gives you an opportunity to explore further. So it opens a pathway for psychosocial care. Next slide. So this is an example. This is distress thermometer. Okay, so this has been developed by the NCCN in USA, MD Anderson, not MD Anderson, the Memorial Sloan Kettering team. So you can see that there is a thermometer, which where you see that the 0 in the thermometer says no distress, and 10 is actually extreme distress. And look at the instructions. It says, please circle the number 0 to 10 that best describes how much of distress you have been experiencing in the past week, including today. So that it is only for the past week, including today. So you have to do this routinely, at least twice a month, so that you're getting the measurement for 2 weeks. So we have to do it routinely, just like you measure pain, you ask this. And the studies have say that if the person says that they have a distress, the distress score is 4 or above, the cutoff score is 4 or above, then he needs help. Is that clear? 4 or above. And the next part of the questionnaire, you see there is a list of issues. Second is indicate if any of the following has been a problem for you in the past week, including today. So you look, there are practical problems, family problems, emotional problems, spiritual existence, and physical problems. This is just to indicate that what are the problems in the person's lives. This doesn't mean that only these are causing the distress, so you have to link between them. You remember that the distress is psychological, the list can be of anything. And next slide, please. So there is actually, we have the scale, sorry, go back to the slide. So this is actually, you can translate this scale into your languages and use the list. It's very easy. We have one in Malayalam, which we have used for studies also. And we had in that tool, we had actually some things in the list, the problems, we had modified it according to the settings that the problems in our settings. Like, like here in the family problems, there is dealing with a partner, or, some things which we feel that is not a very, useful for our settings. You can change it to problems which are very, very significant in your setting. So you can use that. Next slide, please. So going back to Mr. A. So we are screening with the distress thermometer. We showed that he scored 5 for 2 consecutive visits. Okay, we are going back to that person who came to us. He had symptoms. We screened him with distress thermometer. We saw that he has scored 5, that is 4 or above, for 2 consecutive visits. And that indicates that he should be evaluated for psychological distress, even when the distress is associated with physical symptoms. So why I'm emphasizing is this: when we think that the distress is associated with physical symptoms, suppose the person has pain, score of 8, okay, then we think that, okay, it's because of pain, so we need not actually address the psychological distress. So we should understand that psychological distress, even if due to physical symptoms, should be given importance. Does that make sense? So we should take it important as, as a separate thing, even if it is due to pain or any other symptom. And it is good that if he is seen by a trained social worker, psychologist, or a psychiatrist, any trained mental health professional, or a person in the palliative care team who has an interest or has skills or who is interested in this area. Next slide, please. So the questions that we come. So now we did assessment in terms of history. We looked into risk factors. We looked into screening. We looked into functioning. Now we are looking, so okay, now he's got distress. We know that he's worrying. He's actually very irritable. He's not able to sleep properly. He's very panicky. He's got a panic attack. So then the question is it part of an adjustment disorder? So we are now looking into categories that he could have. So remember that at your level, especially social workers, you don't need to actually diagnose. The main thing is to this sessions are you to understand that there are concepts like this. There is something like psychological distress, and at least the team should identify that there is psychological distress. So just actually at least we should enable to identify this distress and open the pathway for psychosocial care. If you're able to diagnose, well and good. I mean, I'm not saying you shouldn't, but even if you cannot diagnose, don't feel that we shouldn't do it. At least get to this point, and then you can take the help of a psychiatrist or a mental health professional. So then, is it part of an adjustment disorder? So adjustment disorder is the commonest category, psychiatric category that you see in a palliative care population. I'm just saying very simple points about it. People who are interested can go into ICD-10. You can Google ICD-10, go into mental health and behavioral disorders section and read about all the disorders. That is, you will have specific chapters on stress-related disorders, specific chapters on mood disorders and anxiety disorders. You can read that. I'm just giving you specific points that you should know. Adjustment disorder is actually a maladjustment process in response to chronic stress. And the chronic stress can be due to a chronic disease. It is usually short-lived, and usually you have a mixture of symptoms and a very labile state. It actually it starts from it follows actually exposure to stress. Like suppose the person has been informed that he's got cancer, a sudden change in his, life, that itself can trigger off a maladjustment process and can lead to a mixture of symptoms of worry, anxiety, irritability, reduced sleep, etc. But anxiety adjustment disorders are usually very short-lived. Usually the person kind of gets into a stage of acceptance, because this happens essentially because the person is not able to cope and adjust to his present state of stress. So the person usually takes around 2 to 3 months and then usually gets back into a stable level of functioning. If the person, even after 6 months, is not able to get back into a adequate level of functioning, then we see that either the person fits into a depressive disorder or an anxiety disorder. Next slide, please. So then we go into, so if the person is not coping well even after 6 months and his symptoms are still persisting, so you think, even if it is anxiety, then you think, could this anxiety be part of depressive disorder? Depressive disorder is the commonest disorder which has been mentioned in research in palliative care. But when you use strict research methodology, you see that the prevalence is usually around 7 to 10%. So in that, the person would have very specifically, they has very depressed mood, that is a low mood which is very profound and pervasive. When I mean profound, the deep quality of sadness, and pervasive, that means the sadness is pervasive and affects the person in different areas of functioning for a longer time. It's not momentary. Like if all of us have low mood for a day or two, but we cope and we then bounce back into a regular level of functioning. But for these people, they are not able to get back into their pre-morbid level of functioning. The sadness is pervasive and it affects every part of their life. Second main symptom is loss of interest or enjoyment. This is also called anhedonia. Anhedonia. Anhedonia is a characteristic symptom of depression. That means a person is not able to enjoy or have interest in activities that he enjoyed before or was interested before. And the third main symptom is reduced energy. Other symptoms which help you in diagnosing. So these are taken from the, like I said, ICD-10 and DSM-5 of specific criteria. Other symptoms are reduced attention and concentration, reduced self-esteem and self-confidence, ideas of guilt and unworthiness or worthlessness, bleak and pessimistic views of future or hopelessness, ideas of self-harm or suicide, very important, and changes in body function, like we said before, sleep and appetite. I have marked some in red, like loss of interest, ideas of guilt and unworthiness, ideas of self-harm and suicide. When you look at depression, there are somatic symptoms or physical symptoms. Like in this, the physical symptoms is reduced energy, reduced attention and concentration, changes in body function. Remember that these symptoms that I said, the reduced energy, reduced attention, the changes in body function can be due to cancer itself. So it need not be due to depression. It can overlap. So we have to give focus into the psychological symptoms like loss of interest and enjoyment, ideas of guilt and unworthiness, and ideas of self-harm and suicide. Remember, I will just give you a tip. Just remember into helplessness, hopelessness, and worthlessness. The three important negative symptoms that a person can have, or signs, that you can elicit from the person's mind: helplessness, hopelessness, and worthlessness. Next slide, please. So then, how do we manage disabling anxiety? So anxiety it can be part of adjustment disorder, it can be part of depression, or it can be part of, I think I missed a slide here. Is there a slide before this? Just go back. I think I'll send that PDF, one more slide, and you can then send the PDF to everyone.
Okay, ma'am.
Because it can be either part of adjustment disorder, it can be part of depression, or it can be part of anxiety disorders. That means the core problem is anxiety itself, where the person is not able to cope because of the pathological worry. That's where I said it could be generalized anxiety disorder or panic disorder or obsessive compulsive disorder. Anyway, you either just identify there is pathological anxiety. And then how do we manage disabling anxiety? So there are general steps, there are pharmacological methods, and there are psychological interventions. Next slide. See, there are no national or international guidelines for assessment and management of anxiety in palliative care patients. Actually, a Cochrane review found insufficient evidence to guide pharmacological treatment of anxiety in adult palliative care population. Just for the information, for people who are interested in the evidence behind it. Next slide, please. So the initial treatment is detect and treat any comorbid depressive disorder. So the first thing is rule out that it is adjustment disorder or depression. Agree to a clear plan. That means you have to really discuss with the patient and the family that there is psychological distress and we have to manage that too. Explain the nature and the cause of symptoms and reassure about specific concerns. Identify and reduce or avoid any stressors which is specifically causing anxiety. Suppose it's due to chemotherapy, we cannot avoid it, but we can reduce what is making the situation anxious to the persons, or we can give them extra support to reduce the stressor. And also advise self-help methods like how do we like time management, taking time off to relax, talking to your friends and family, all those simple self-help methods to look into anxiety. Next slide, please. Pharmacological management basically is antidepressant. So even for anxiety, I took anxiety especially because we always talk about depression, but we do not talk about anxiety, which is a very common symptom. So whether it is anxiety or depression, that's the treatment is antidepressants. Because always what we do is in anxiety, we give benzodiazepines like alprazolam or lorazepam or clonazepam. That is not the drug of choice. The drug of choice for anxiety as well as depression is antidepressants, and the commonest group we start off with is SSRI or the selective serotonin reuptake inhibitors. For example, escitalopram, fluoxetine, sertraline, paroxetine, many examples. I have given common ones used. Fluoxetine 10 to 60 milligram, escitalopram 5 to 20, sertraline 25 to 150. And remember that you have to start in a small dose and slowly titrate up. It takes at least 2 weeks for specific changes to happen. So it is not going to give you an immediate change in the depression or the anxiety. No major side effects for this group of medications. Just keep in mind that there might be nervousness in the initial few days. In older patients, there is evidence that there could be gastritis, gastric bleeding, or hyponatremia. Elderly patients, SSRIs can cause hyponatremia, so we should be very careful because the same person could have had delirium as well. So hyponatremia can precipitate delirium, so we have to be careful. Next slide, please. Other useful medications are SNRI or the serotonin norepinephrine reuptake inhibitors like venlafaxine and duloxetine. These are also used for neuropathic pain. And NASA, the noradrenergic and specific serotonergic antidepressant. The commonest that we use very routinely now is mirtazapine, 7.5 to 30 or even 45 milligram per day. Low doses are useful, especially in people with sleep disturbances like 7.5 milligram. We can even give half of 7.5 if it's a very elderly person. Next slide, please. Remember, benzodiazepines is a commonly used group like lorazepam, clonazepam, and alprazolam. It's very useful for acute anxiety or panic attacks, but it needs to be tapered off after the acute episode unless in terminal states. Like in terminal restlessness, you can use it, but if the person is continuously having anxiety, don't use it only for short periods of time because otherwise the person can get dependent on it. The common ones used, as I said, is lorazepam, clonazepam, and in terminal states, use midzolam. So lorazepam 0.5 to 2 milligram TDS once to TDS, clonazepam 0.25 to 1 milligram TDS, and midzolam 0.5 to 2 milligram per hour, especially in terminal states. Next slide, please. So there are other groups of drugs, tricyclic antidepressants. We are familiar with it because we use imipramine and amitriptyline for neuropathic pain. Remember, we use amitriptyline for neuropathic pain in 25 milligram tablets. It was the first group of antidepressants that we were using. We can use it if we know about the side effects, and it is probably the most used universally, familiar drug for globally, but it has got a broad range of side effects. So to have an effect on depression and anxiety, it is not enough to use it in the dose of 25 to 75 milligram that we use in neuropathic pain. We have to go beyond that to 150, 200 milligram, which will bring again side effects also. So it is better to use the earlier group of drugs that I said. But remember that if a person is already has on amitriptyline for neuropathic pain, 25 milligram, and has just mild anxiety and some sleep disturbance, you can slightly increase the tricyclic NC rather than adding a new group. Another drug is trazodone, which is used in elderly, especially for insomnia and anxiety, 25 to 150 milligrams. But starts low and slow. Next slide. I'm just going through briefly because I think we are getting close to the time. I'm just going through the psychological interventions quickly. One is relaxation methods. So we can learn it. Nurses, especially deep breathing techniques, yoga, meditation, progressive muscular relaxation. Distractive methods where a person is helped to distract from the source of stress by imagery, like visualizing a pleasant scene or situation. Cognitive behavior therapy, which focuses on his thinking, cognition, and behavior. Supportive therapy and problem solving therapy. So these are the psychological interventions that we usually use. Next slide, please. So there is something called family therapy also, where because we know that interpersonal and family relationships can affect chronic disease management outcomes. So family focused intervention directed at crisis intervention, conflict resolution using advanced communication skills within the family, where if there is a conflict also helps in reducing the distress. Next slide, please. There is newer evidence for meaning-centered therapy. There's something which is coming up, which is called dignity therapy, especially in end-of-life care, where we have to focus on dignity for the person. Hypnotherapy. So there are several psychological interventions which you can read upon if you want to. I'm not going into the details of each one of these. Next slide, please. So we are going back to Mr. A. So Mr. A has anxiety issues, and we should remember that it has to be addressed separately and not be left as part of the morbid terminal illness. He will definitely benefit from a course of antidepressants with benzodiazepines used in the acute state. Regular psychotherapy will provide equal and sustained relief. Screening and exploration for new issues should continue through the journey with him. This should not be just for one time. We should continue the process, and he will benefit from an improved quality of life, which is the aim of palliative care. Next slide, please. Thank you.
Thank you, ma'am.
Yes.
So that was a wonderful class on anxiety disorders and everything. So we now understand what depression is all about. We always use a word randomly, like she's having depression, he's having depression, everything. So these are actually disorders, right, ma'am?
Yeah. So that is why we should never use casually, like, this person has depression, and of course, a person can be sad, but we shouldn't label them. We should be careful when we say the person has depression, rather than loosely using such terms. These are clinical disorders: depressive disorder, anxiety disorder, adjustment disorder. Of course, you can say that the person is distressed.
Distress, correct. At least he's having some anxiety issues, but we ran directly
Yeah.
saying he's depressed.
What happens is usually we label them saying that, oh, he's a difficult person, or he's a psycho. So these are the terms that they use, psycho kind of thing, which is actually very, very inappropriate and probably not right to do that, because it actually adds to the stigma, and you're actually not giving him any better quality of life.
Like by saying these words, we are in a culture like these are common things and something which can be avoided also. Like that person is depressed, okay, fine. It takes some time, he will be coming up. So
Yes.
we need to give more importance to while using such words, and we understanding the disorder more.
I think when we look into the physical symptoms, we should also give, we should be trained, and we should develop skills to communicate and explore for such issues, and start documenting it, start routine screening, so that when you're looking at a person, you're not looking only into the pain and nausea, constipation, vomiting. That's what we usually do, isn't it? So also ask few questions like, what is happening with you? How are you feeling? What are your thoughts now? Are you worried about something, or is it something causing extreme concern to you? So such questions actually will help explore what is beneath certain behaviors and certain questions from the person.
Thank you, ma'am. So the session is open for discussion. You can raise your hands or yes, Pranav sir. Yes, sir, you can speak. Sir, we can't hear you. Pranab, sir? No, sir, we can't hear you. Sir, I suppose there is some problem with your headset or your volume is very low. So you can correct it while we can move to some other. Anyone else have a doubt or comment to say? Your experience with patients like that?
Can we go on then? Further?
Yes, ma'am, we can go. Pranav sir, you can chat your comment while we will move on to case presentation, and after that we can come up with your doubt clearance. So today we have Grace Susan to take a case presentation for us. So she is a social worker from Ganga Prem Hospice, Uttarakhand. Over to you, Grace.
Thank you, ma'am. I hope I'm audible to everybody.
Yes, you are. You can continue.
Good afternoon, everybody. Today I'm here to speak about a case that I have dealt with, some mental health issues, and he has some diagnosis. So let's look into it. Next slide, please. So he's a man who's 60 years old. He is diagnosed with squamous cell carcinoma, right lung, or small cell carcinoma. Stage 3, bilateral pleurodiffusion, rheumatic carcinomitis. The medicines he's taking is TAP, Pantop 40 mg OD, morphine SR 10 mg BD, morphine IR 5 mg SOS, Alprax 2.5 mg BD, Siraplax 2 tablespoon TDS, haliperidol 0.25 mg BD, nebulization with Ulonium TDS. Next slide, please. So this patient is living with his wife and 2 sons. One of the son is outside in some other country, and the other one has one of them has a son and one of them has a daughter. They have a very strong relationship. There is no family. I mean, the grandparents of the parents of the patient is not there. They have shifted to Dehradun since quite long time, and so they are a nuclear family, a joint family with their children and grandchildren. Next slide. So his illness of history and experience with healthcare system so far. Patient was initially presented with complaints of pain in the chest at AIIMS Rishikesh 1 year back, and after a series of tests was diagnosed of cancer in lung. He initially took Ayurveda, the alternative therapy, and after that, when he was getting very severe, he had gone to the hospital, and where he received 1 cycle of palliative radiotherapy. He's currently on and off oxygen. The symptoms that he's facing is pain, difficulty in breathing. He's confused. He's having a lot of hallucination and listening. Next slide. Family psychosocial history. Family history. The family patients include his wife and 2 sons along with their family. No history of cancer in the family. Mental health problems. The patient says that he wants to die. Wife is very emotional and wants the husband to be cured. Sons want their father to be comfortable. Next slide. Other social challenges are patient initially was a smoker. He was working in a sugar factory. He was a foreman, and he has keen interest in farming and gardening. The available social support available is family is very supportive. They live together, the sons and their wives and their children. So they're very supportive. Next. Ma'am, next. Financial condition, they have this own house, though they are lower middle class. 50,000, they have a debt for initial treatment that they had been doing for Ayurveda. They had been taking medicines from the mountains. And all the other treatment that has happened in the hospital has been done through Ayushman card, which is a new scheme from the government. Next. Education and job status of children. Patient's wife is a housewife. He's completed her high school. Elder son is working as a graduate engineer in private sector, and younger son is a graduate teacher at school. Patient's insight on diagnosis and prognosis. Patient is aware about the diagnosis and prognosis. And the doctor has explained everything to him, and he's aware about it. Caregiver's insight on diagnosis and prognosis. Wife of the patient is aware that about the current situation, terminal condition. However, she is in denial. All others are aware about the diagnosis, but only the two sons and their wives know about the prognosis. Wife is told, but sometimes she's in denial. And next. MSc of the MSc status of the patient is appearance is sick, dressed well, poor eye contact. Behavior is patient is restless, irritable, soft, confused. Mood affect is disturbed, rapid change. Thought process is unorganized. Thought content is varied thoughts, hallucination. Cognition is varied thoughts and hallucination. Cognition disturbed, poor memory. And inside, patient is aware of the diagnosis and aware of prognosis. But when it comes to family, can you hear me, ma'am?
Yes, you can continue.
Caregiver is the main person that was with the patient in our hospice was the wife. Her appearance is tired, shabby dressing. She looks sad, but she's cooperative. She wants to express her feelings. Behavior is she maintains eye contact, changing body movements. Although her speech is very fast and very loudly, and she's repeating the same thing that with regard to the patient, that the patient has to be better. Mood and affect of the caregiver is anxious and irritated about the patient's condition. Why is he not getting better? We had tried all the treatment. We had taken other medicines. Thought process is of the wife is organized. Thought content is normal. Cognition is conscious and oriented. Aware of diagnosis but is in denial. The other psychosocial assessment major concerns that we found is the treating doctor has diagnosed of delirium according to the symptoms, because the patient keeps telling things that are very different in the condition in delirium if you detailedly study about it. So the treating doctor has said that he has delirium, and patient and family initially they didn't know about delirium, and because they say that why is he talking about other things every time. So then they were explained about the condition, and they were explained that he might show some more symptoms like that, and then provided end of life counseling to family. Next. The goal of psychosocial care is educate family in understanding the new diagnosis of the patient at the end of life care, especially with regarding the delirium. Assisting with home care service as we provide home care service. Helping with coping strategies for the patient and the family. Non-pharmacological interventions for management for breathlessness, because patient has a lot of breathlessness. And counseling with patient and family for new concerns. So we are hoping that
Grace, are you there? Grace, are you there? I think we have lost Grace in between. On behalf of her, I'm summarizing the case presentation. The patient is diagnosed of non-small cell lung carcinoma since the past 1 year. Patient is living in joint family with wife and two sons that are married, and they have one son and daughter respectively. Patient is aware of diagnosis and of prognosis. Wife is in denial. Patient didn't take any active medical treatment initially, took alternative therapy. Family is supportive. Okay, so we have two discussion points from Grace. What are the main mental health concerns of the patient which should be recognized? What are the psychosocial care goals would you suggest for the patients and family? So first we wish to hear from our participants on what are the main mental health concerns of the patient. So anybody could voluntarily come up and speak. Divya, would you wish to add something? I suppose you have been seeing many people.
Actually, the delirium part, which Grace said that it has been diagnosed by a doctor who's been treating, and as the wife is in denial, I think she needs much attention and support. And being wife as a life partner, if she comes to know about the whole process and about the prognosis clearly, she can play a major and a vital role in the mental wellness of the patient. That is what I feel like. I think the patient's wife right now, uh, we need to help that lady understand, and then automatically the patient will get better with her help also. That's what I feel.
Thank you, Divya.
Yeah.
Baisali, will you have something to add on? Well, no. Dr. Chitra?
Yeah, so this is entirely something new in terms of delirium. So I'm not going into the diagnosis of delirium or management of delirium, which is another psychiatric disorder. So in this, as somebody pointed out, Divya pointed out, denial, of course, is an issue that we have to address by your communication skills, um, exploring her concerns, what she understands by the understanding about the diagnosis as well as prognosis. But before that, I would want to go back to the slides. Is that okay, Rajalakshmi?
Yes, ma'am. Mental state.
I just want to see, because I'm not going to focus on what we should do in terms of managing the person or the wife. More is important about how you're assessing the person and the wife.
Sure,
So
ma'am.
the process is very important for us to learn before we jump into, you know, what we are going to do. So I'm just going to point out a few things, because I remember, like, how when I said how do we assess, what do we ask the person. So that is to see what I see from even the psychosocial presentation is that, can you hear me?
Yes, ma'am, we can hear you.
Is that the assessments are generally very superficial in terms of psychosocial. Can you show me the slides again, her slides again? See, remember that this is a part of learning. I'm not criticizing, but just pointing out to how we can improve on our assessments. Okay.
Okay, ma'am, you can continue. That
Yeah,
would be
just
great.
show me the slides that Grace showed, Grace presentation. Can you share it again?
Ma'am, can you see it?
No, yeah. So go ahead. This is okay. Go ahead. Go ahead. Go ahead. Again, once more. So this is this slide I want to look into. So this is where you start with psychosocial history. So as far as I see in both the headings, family history as well as mental health problems, I don't see anything which actually elicits anything regarding to psychosocial concerns or mental health problems. See, the thing is, under the heading mental health problems, it is said that patient says he wants to die, wife is very emotional, wants husband to be cured, son wants their father to be comfortable. Is it a problem? I find these are normal things that people would say. See, every son would want their father to be comfortable. Every wife would want a husband to be cured. A patient who is in pain or has symptoms would say, I want to die. So we cannot label it as mental health problems. Similarly, when you're looking into the family history, you're saying the patient's family includes his wife, 2 sons along with the family and no history of cancer. That is a regular history that you're taking. So what is the psychosocial history in this? Do you understand what I'm saying?
Yes, ma'am.
So what I'm saying is, let's be more specific and let's go into the details of these things. So what are we going in family history? What are we looking into when we are looking to psychosocial history? We are looking into when we are looking into family history, we should say how is the family structure, who is the who earns for the family, isn't it? Who is the breadwinner? Who brings in the monthly income? Who gives the emotional support to the family? Who makes the decision in the family? Do you understand what I'm saying? So that is psychosocial history. What are the relationships between these people? So it is said that it is very supportive, very generally. But we should go into detail. How does the wife react emotionally? What is her understanding? So a bit more in detail about the patient's family. No history of cancer. So when you're into psychosocial history, what we in the family history we should say, is there any history of mental health issues in the family? Is the son drinking, or the father was there drinking the father was drinking substance use? Has there been any issues of conflict? Is there any conflict in the family other than, regarding to the illness? Is there any property issue, or is there any other areas where they do not agree? So we have to go into detail into psychosocial. Here I don't see any psychosocial issues. And mental health problems also, these are not mental health problems. We should not put this into the setting. These are concerns of the patient and the wife that we have elicited. We have elicited a concern that the person with this illness is telling us, I want to die. That is a concern, isn't it? That is actually alerting us, saying that, oh, why is the person saying that I want to die? We cannot label that he's got a mental health problem. Similarly, the wife is very emotional and wants her husband to be cured. Which wife wouldn't be emotional or, average? Of course, when there's a very great conflict, we don't know, but generally an average family family would react the same way, isn't it? Are these mental health problems? Do you understand what I'm saying?
Yes, ma'am. We do understand, ma'am.
So from this, we have to pick what are the problems. So if you're saying that the person is saying, I want to die, requesting for death, that is a concern that we are picking up. And further to that, we have to explore, why is he saying that? Is he worried? Is he anxious? Is he sad? We are going back to that system of assessment that I had spoken about. Remember, I said, how do you assess? How did he cope? How is he coping now? Has he coped well in the past? So this history should be fitted onto that system of assessment that I had spoken of in those slides. And I think it's very possible to do that. Am I making sense?
Yes, ma'am, you are making sense. I think we really need to work on it, and we need to make things.
Right. But I need to go to 1 or 2 slides more. I'm just pointing out that let us be more give more details when we are presenting also. So one is here again, social challenges. I didn't understand social challenges. Like patient is a smoker is a challenge, of course. But what is about the patient being a foreman in a sugar factory and that he has keen interest in farming? That's a good thing, actually. Actually, you can help him cope by distracting him, and if he's able to do some activities, we can help him go to the garden or plant a few. So that's a good thing actually. So I don't know what she meant by social challenges here. Of course, smoking is a social challenge, but again, in a person with advanced cancer, is smoking actually a challenge? Are we going to ask him to stop smoking, or are we looking into the preventive aspects of smoking generally? Like we are saying that we want to prevent him smoking so that others around him don't develop cancer. So we have to pick up these issues. What are we actually saying when we bring these points? Is that clear? So social support, okay, I agree. Family is but that's a very broad statement to say family is very supportive. How are they supportive? Are they supportive financially, emotionally? Who brings the patient to the hospital every time? Who is the primary carer? Who makes the decisions? Is it clear what I'm saying? How are they coping? The family itself, how are they coping? How are the children in the family? They have children, families, wives. So are the children going to school? Is the other family coping well? Is the functioning the family going on? What does that man know? I mean, what is the how much of property does he have? So because they say he's aware of his prognosis and diagnosis, has he talked about dying, where to die or how to die, or any concerns about dying to his family or to the primary care team? So these are the things that we should elicit. This is very broad. So please, when you start looking into psychosocial history, try to look into details. When you say each statement can actually be explored further to bring in more details. Next slide, please. Okay, this again can be explained further. So loan and debts, 50,000 rupees. So to whom does he have to pay it back? How should he pay it back? Will the son pay it back? So will this Ayushman card help him in paying back anything? So I am not able to get any kind of other details from these three statements. Okay, next slide. Okay, so see, the elder son is an engineer, the younger son is a teacher. So they're not actually from very, I can't see that they're very, they're not like very, very poor. They have some monthly income. So what is the monthly income in the family? The patient's wife actually has completed high school. She's not an illiterate. So what is her understanding? Does she know about cancer at all? We usually say that the person is in denial. It's very easy, like you said about depression. Remember, let us be careful when we use terms, even like denial. So when you want to say the person is denial, you have to really check her understanding. She should really understand about diagnosis, prognosis, and still not able to accept the reality. So have you made an attempt to really give her information? Is she uncooperative because of denial? So all these things should be again looked into. Next slide. So again, this is about the denial thing. So that we have to look into. Next slide. So this is again, I want to, because this came in the last presentation also. Rajlakshmi, you will remember, I don't know who presented last time, because this mental status examination came. Remember, I totally agree that mental status examination is very important for assessing mental health issues. I agree. But let us learn how to do it.
Yes, ma'am.
So we shouldn't be, I mean, I don't have time to go into the details of how to do mental status examination, what should be included. So here I find this incomplete, and sometimes some are overlapping and not clear at all. I'm sure that she must have done it, and probably the way she expressed must have been different. So we have to be careful, because hallucinations is never part of thought. Delusions are part of thought, but hallucinations is something called perceptual disturbances. So I'm not going to the details of that, about how we do mental status examination. When you look into thought, you look into thought content, you look into perceptual disturbances, and that is where there is a disturbance in your sensory processing. That means like you have either hallucinations or illusions. So here we have to be really, we should have, and I suggest that we could actually have a common framework of how we can do mental status examination. So that everybody does in a similar way. And what are we asking? So what are we asking in each heading, like appearance, behavior, speech, mood and affect. So here mood and affect, it says disturbed and rapid change, but we are not understanding whether the person is anxious, irritable, or depressed, or what is the mood like. That is not said. It's just said disturbed. It's very general. Whereas for the caregiver, it is very clear, anxious and irritated. Do you understand?
Yes, ma'am.
We have to be slightly more specific in our assessment. So what I would advise or suggest is that we focus on assessments. How do we assess the person? From the history, from what questions we ask, how we screen them, and what symptoms we elicit. Very important. And that will lead half the thing, you will lead into, you need not worry about the diagnosis. I think here we need not even worry that it is delirium or depression or anxiety. Because in the next slide she said, according to the doctor, it is delirium. But according to what we see, the wife is in denial, and we are not sure whether the patient has any other issue. So let us focus on assessments a bit more in a structured way. Next slide, please. Okay, this is again, but I didn't, okay, she's not, so this is about delirium. Okay, that's okay. Next slide, please. This is also okay. So summary doesn't say anything about psychosocial concerns, except that the wife is in denial. So I want us to be more clear on what we mean by psychosocial concerns or mental health concerns, and be specific in our exploration for those concerns. That is what I would suggest. Any questions we can discuss? I hope I made sense, because with what I had taken in the last few sessions and what presentation happened today, I just wanted that to kind of, overlap on what we spoke about. So with that, I think we should, our assessments the focus should be on assessments.
Thank you, ma'am. That was really a detailed explanation on how to assess things. So keep these things in mind while you're coming up with a case presentation from next time onwards. So is there any more doubts?
Because I'm not sure, do we say in ECHO that the presentation should be very simple and brief? Is there a requisite like that? Do you say that the presentation should be very simple and of only 1 or 2 lines?
We not like ECHO India haven't specified anything like that, ma'am.
Okay, so then I think we have to also look into how the presentations are in terms of the information that is shared.
Yes, ma'am. Pranav sir, can you? Yes, ma'am. Yes, sir.
Now, am I audible?
Yes, yes, you are.
To Dr. Chitra ma'am, one clarification is I want to know, psychological distress are highest among patients from rural areas and among female patients compared to male. As you told that female are at high risk, but why? Why female?
So females are at, for some disorders, female are at a risk than men, like depression and anxiety. Female are at a risk. The reasons that have been set for that is because of many reasons. One is the hormonal and the neuroendocrine axis itself. That is, a woman actually goes through several phases in her life, like from menarche, then postpartum stage, and then menopause, which includes a lot of changes in endocrine and hormonal. So there is a lot of body changes, as well as each important change in the woman's life. There is a psychological change also. Like a woman has a menarche and then gets married, has a child, then menopause. Each of these physiological changes has a psychological impact. And also, if you look into some disorders like hypothyroidism, is more common in women, which also is linked with psychological issues. So, and also generally in these conditions, the female psyche, because of the multitasking and the stress, the exposure, and because a woman now is expected not only to work outside but also take a, like earlier it was only nurturing, but now she also works outside, nurturing everything together. So there's a great deal of burden for a woman in today's society. So that is another social cause. So there are several causes. It is not because a woman is weak,
So
physically or mentally. She's not weaker than man, but she has biological and physiological risk factors compared to a man for these disorders. For example, sir, if you look into schizophrenia or bipolar mode disorders, that you will see men have a slightly more higher risk than women. So it is depends on the different psychiatric disorders. It is not that all psychiatric disorders women are more vulnerable.
is there role played by counselor in this case?
In which case?
Counseling plays a vital role. I believe so.
In what, sir?
In motivating the patient, especially female who are at a high risk of psychological disorder, mainly depression, anxiety, OD, or something like that.
I think we are not looking into that aspect now. I mean, it's not about females alone. Men, we actually spoke about a male patient and counselors. So we are actually kind of, I think, sir, here we are talking about distress. So I'm just saying women are at a, that is actually an evidence point of view. Doesn't mean that men cannot have distress. So we are discussing a male patient actually. Counselors have a role in motivating everybody. So
Ma'am, another clarification.
Yeah.
When the patient illness experience in relation to the illness requires a complex set of communication skill from the social worker or from our side, what are they? This communication skill will relieve the distress. Is there any communication?
Very important, sir, because I think your own communication skills, how good they are, how appropriate you use them. It's very important in terms not only in offering support, but right from the start in assessment. Very important because it depends on how you ask, how you interpret, how you explore further for concerns, and also your own advanced communication skills into challenging or dealing with emotional reactions of the person, or offering therapy in terms of support, or solving problems, or exploring into further concerns from the patient and the family. So very important that you get trained for communication skills. I'm not talking about general communication skills. This is about set of specific skills that you have to address psychosocial concerns.
Actually, I experienced from my own home with my missus this type of conditions I faced, and my missus faced. That's why I am asking you that for clarification.
Of course, sir, you will definitely benefit from having a professional, offering counseling and some therapy if there is a mild amount of anxiety or difficulty in coping, or if there is a predilection for anxiety and depression. Definitely, sir.
Thank you, ma'am.
Thank you, sir.
Oh, one thing, ma'am.
Yes,
is there any role of palliative psychiatry when loss of capacity at some point in the dying patient?
I didn't get you, sir. Can you repeat the question?
Loss of capacity is very common in palliative care patients. Those who are undergone palliative care. Almost all patients lose their capacity at some point in the dying stage. Then, is there any role of palliative psychiatry then?
What do you mean by palliative psychiatry, sir?
Palliative psychiatry means there has been growing interest, the concept palliative care, the patients who are under palliative care, psychiatric, psychosocial system challenges, psychosocial
Yes, so
method.
that is exactly what we are discussing.
Yeah,
That our own palliative care patients, cancer patients, or any chronic disease, whether they are in the beginning state or whether they are in the terminal state, they would have psychological concerns, and there's definitely a role of psychiatric interventions in those groups.
okay, ma'am. Thank you. Thank you very much.
Thank you, sir. Any more queries? Nidhi?
If there are no questions, I would like to leave. And if there's any technical things that you want to discuss with them, you can continue, Rajalakshmi.
Okay. Ma'am, 1 second. Nidhi, were you having something to say? No, okay. Okay, thank you, ma'am. Thank you, ma'am, for joining in.
Thank you. Bye. Thank you.
Bye. So I have shared the feedback in chat option. So please do your feedback before logging off. So this echo concept is completely of interaction. So it would be good if you could come up with some questions in between. Otherwise, it will be only a one way of communication.